as you mentioned, is a very highly selected population. I wonder, were there any clinical characteristics that you noted in the patients who were in this highly selected population that did benefit initially and then also had benefit with retreatment? Did you notice any trends there?
Yeah, so I think an important trend we took note of, and unfortunately there weren't kind of specific tissue-related or tumor biomarkers that we pursued as part of this study. Those weren't available. But an important characteristic I think this study did highlight is that responders to Rechallenge had a longer median treatment-free interval. So basically, if the patients are off treatment longer, um, they are more likely to respond. So among those who responded, the 41%, the median treatment-free interval between the initial treatment and rechallenge was over a year. It was 13 months. For those who did not respond, it was 8.5 months.
Mhm.
Potentially an interesting difference there. I should also highlight, again, safety and the toxicity of this treatment with rechallenge is important to assess here as well. And we did not see any new safety signals with this combination. So treatment-related adverse events of any grade with Rechallenge were just a little less than 50%, were 45%, and most were grade 1 or 2. There were only 6% were grade 3 or 4. No treatment-related deaths, so no grade 5 events, thankfully. And this is again about what you expect with Pembro treatment. We didn't see any increased toxicity in this, again, small and selected subset with Rechallenge.
Yep. How do you fit these findings into the context of a very rapidly evolving landscape? So we have moved now with the, introduction of EV Pembro in the first line locally advanced metastatic setting. What about now with the approval of NIAGARA? So chemoimmunotherapy in the perioperative setting, and we're waiting hopefully this year, additional perioperative studies to read out. How Where does this place this into context, especially now with also the approval of adjuvant nivolumab? So it's just a very rapidly evolving space. How can we, define the role of immune checkpoint
Yeah.
inhibitor retreatment in our current landscape? So either after perioperative treatment or even in those who are getting EV Pembro, completed 2 years of pembrolizumab, is there a role for rechallenge there, or how can we answer that question?
Yeah, no, that's I think you're highlighting really the critically important question here, and again, one that we're facing in clinic a lot with the direction in which the landscape in metastatic urothelial cancer has moved. And I think this publication was actually quite timely. It worked out that way because it just took a long time, as it usually does, to get this together and then to get it accepted. But I think it came out actually at a fairly good time, right? As we're using EV Pembro more and more in the metastatic setting, and right as the Niagara regimen, actually, the data came out, and now that regimen is also approved in the perioperative setting. Since around 2021, we're already using a lot of adjuvant nivolumab. So many patients were getting exposed to immunotherapy before the metastatic setting, right? And
Mhm.
and over the past year and a half in the United States, at least, we have many patients, most patients in the frontline setting, really getting, at least at academic centers, but increasingly in other places as well, getting EV and pembrolizumab as their frontline regimen, right? So many patients will be getting immunotherapy early on. And then when they then progress, or if they progress, then we're faced with that question, or can we give them, more immunotherapy? And that's really the critically important question here. And of course, now with the approval of Niagara regimen, which literally happened just like under 2 weeks ago, right? It was on March 28th. Um, we will have many more patients actually getting it in the perioperative setting, right? So this data, although with a different regimen and even somewhat, of course, dated regimens, right, that we don't really use pembrolizumab monotherapy all that much anymore, right? But I think it suggests it gives us important data and important clues of which patients can benefit from immunotherapy rechallenge. Because, I mean, I certainly think it's not all patients, and I think there are large phase 3 trials done in RCC, right, done in other tumors that have shown us this, right, that for all comers, for the entire patient population, rechallenge with immunotherapy probably will not work very well. Um, but for some patients, it probably will. And a study like this, again, gives us clues of who those patients are. And those are probably patients who, on the one hand, have had pretty good benefit with prior immunotherapy or immunotherapy-based combinations. And then probably patients who did not, well, so certainly patients who did not progress on it right away. And then, there's potential greater benefit for patients who then were off immunotherapy treatment longer, right? That treatment-free interval, as I mentioned in this study, was longer in responders to immunotherapy rechallenge than to non-responders. So I think this post hoc analysis of 49 patients can give us important clues and is hypothesis generating. But these are things we need to test prospectively, and there are trials that will be investigating immunotherapy challenge prospectively in
Yeah.
urothelial cancer as well, but they will be in more select patient
Mhm.
populations. And we have to be again thoughtful about who those how to define those patient populations, and I think a study like this does provide important clues. And
Mhm.
then when of course we see patients in clinic, we can apply this as well, right? And so someone, a patient who had prior immunotherapy, and many patients will now, and maybe progress shortly thereafter, maybe immunotherapy rechallenge is not the best option.
Mhm.
Maybe we should reach for other things and other options that we have, like antibody drug conjugates and a plethora of other things that are available. But patients who, had, let's say, adjuvant immunotherapy treatment 2 years ago, had in a few years, we'll have patients who would have had NIAGARA regimen 2 years ago and were off treatment for a while and then progressed with metastatic disease.
Mhm.
You can probably reset the clock with metastatic disease and re-challenge those patients with immunotherapy-based combination. That's my hunch and my hypothesis from this. But again, that's something we need to look at more and in greater depth.
Yep. Very good. Well, thank you for sharing with us. What is, in terms of this project, do you have any additional plans for what you will be investigating in the future, or this is kind of what you answered your
Yeah.
question, you'll be looking at
Yeah,
the future?
that's a great question as well. I mean, in terms of what we can get out of this data set, this is probably largely it. I mean, it would be nice to, of course, have a opportunity to look at biomarkers and tissue and tumor-based biomarkers and things like that. But that is often more challenging, even in yeah, data sets from prospective studies. But I think really the value of this is in informing future studies and future prospective trials.